Good afternoon, everyone, and thank you for the invitation to speak. Today, we're going to look at the ethical challenges involved in COVID-19 vaccination in South Africa. As you can imagine, this is a rapidly evolving field, and as this is a pre-recorded talk, apologies in advance in the event that any information is outdated. We're all well aware of the prevalence of COVID-19 in the country, and this is a reported prevalence. However, there's always been some level of debate surrounding the accuracy of our data. There's been an interesting study conducted recently and reported by the South African Blood Transfusion Service regarding the prevalence of anti-SARS-CoV antibodies in 4 different provinces in South Africa. This study was conducted during January and involved only 4 provinces and clearly only blood donors from these 4 provinces. And what the researchers found was that the prevalence of antibodies in the donors from the Eastern Cape was 63%, from the Northern Cape, 32%, from the Orange Free State, 46%, and of course from KwaZulu-Natal, 52%. Now, if we take these figures into account, what it means is that the prevalence of COVID-19 in South Africa could be much higher than is reported in our daily stats. When we think about the variant in South Africa and the impact it has had, we can see very clearly that between the first wave and the second wave, there was a considerable difference in terms of number of cases, number of hospitalizations, and number of deaths, ascribed to a large extent to the increased transmissibility of the variant. Now, when we start to talk about ethics and vaccination, one of the broad ethical questions that arises relates to access to vaccinations or vaccines at a global level. It becomes extremely clear from this particular slide that there is gross inequity between access to vaccines in high-income countries compared to low- and middle-income countries across the world. You can see from the dark blue areas that countries like the UK, the USA, Canada have had considerable more access to vaccines. However, the number of doses administered differs considerably, and we'll talk a little bit more about that later. Now, Canada and UK specifically have ordered the most vaccine doses per person. And so there's a large degree of stockpiling occurring. Canada in particular has ordered 5 times the number of doses required for their population alone. In the UK, there is also considerable access to vaccines and administration of vaccines, to the extent that the World Health Organization recently urged Britain to pause their COVID jabs after treating vulnerable people and possibly to help poorer countries. Of course, whether this will happen or not remains to be seen. Now, this is a very interesting reflection of the actual doses administered per 100 people in the various countries. And what is particularly interesting is that the only African country that features is Morocco, and that despite Canada having ordered 5 times the number of doses required for their particular population, administration is relatively low. And so what is important about any vaccination program is not only having the vaccines, but actually getting them into arms and vaccinating. So despite the global inequity in terms of access, administration of vaccines also remains fairly variable across the globe. If we come to South Africa, we know that there have been a number of ethical debates, political debates around access to vaccines in this country. And so discussions initially started around why researchers had not negotiated access, with the chair of the Vaccine MAC leveling accusations against researchers for not ensuring access to vaccines. From other parties, we've had accusations leveled against the government for the delayed access and procurement of COVID vaccines in South Africa. From the research participant perspective, it was interesting to note in this piece written by a participant that there was a level of disappointment around the fact that despite South Africa hosting a COVID vaccine trial, there seemed to be no advantage gained in terms of leveraging fair pricing agreements. We know that South Africa paid in the region of $5.25 per dose for the AstraZeneca vaccine compared to European countries who paid about $2.16 per dose. And so questions arose over why South Africa would pay double the cost of European countries. Now, we do know that Europe invested financially in research and development at a very early stage. But research participants argue that they too invested time, effort, and risk to their health and lives in enrolling in an experimental vaccine study. And surely where 2,070 research participants were involved in the local AstraZeneca vaccine trial, that should have been taken into account in terms of negotiating fair pricing agreements. Researchers, on the other hand, argue differently. Some argue, and it is quite evident in this particular piece in the conversation, that researchers only have a scientific responsibility with respect to clinical trials and that they do not have a duty to negotiate for access after the study. We, however, argued in this piece that from a research ethics perspective, that researchers in clinical trials have both scientific obligations and ethical obligations. And one of the ethical obligations is to ensure post-trial access to investigational products if they prove to be efficacious, as well as benefit sharing agreements, which researchers themselves are able to negotiate at the outset of a study. It does not constitute a conflict of interest, nor is it an undue inducement. And of course, we know that there are international guidelines like ICH GCP that requires trials to be conducted in a consistent manner, ensuring the highest scientific and ethical standards. Now, clearly, research ethics committees that approved these studies also have a role to play in terms of ensuring that there is some level of negotiation at the outset of a clinical trial relating to post-trial access to efficacious products. So despite the many ethical and political debates that were going on in this country, on the 1st of February, we had the arrival of the AstraZeneca vaccines, all 1 million doses, and there was great excitement in the country and a great hope in terms of getting this pandemic under control. Sadly, we know that things evolved differently after the vaccines were already in the country. But despite this, there was enormous discussion around how these vaccines would be fairly allocated, taking a number of ethical principles into account. Now, internationally, a number of organizations started working on vaccine allocation frameworks a while ago. The World Health Organization, the National Academies of Medicine, Engineering, and Sciences in the United States, the CDC, as well as Johns Hopkins and many other institutions and organizations as well. Likewise, in South Africa, we had an allocation framework that very broadly follows a phased approach, very similar to the National Academies of Science in the USA, where particular groups of people were prioritized for access in 3 different phases. And as you can see, phase 1 includes frontline healthcare workers. Of course, phase 2 looks at different types of essential workers, teachers, police, etc., persons in congregate settings, persons over 60, and all those over 18 with comorbidities. And finally, phase 3 looks at other persons over the age of 18 who were not included in phase 1 and phase 2. At a more granular level, what does phase 1 look like? So in addition to just looking at frontline healthcare personnel, both in the public and private health sectors, home care workers are also included, as well as traditional healers. And clearly, the inclusion of traditional healers is unique in the South African setting. So the ethical question is, if we look at prioritization frameworks, why would anyone allocate priority to healthcare personnel? That's a fairly straightforward. There's a fairly straightforward answer to that. We know that healthcare workers have been at considerable risk throughout the pandemic. In South Africa alone, 40,000 healthcare workers have been infected, of which just under 7,000 were hospitalized. And we know that very sadly, we had almost 663 deaths amongst healthcare workers. And so that is very clear evidence that this is a group that is at high risk. We also have a reciprocal obligation to ensure access to vaccines for healthcare workers, given that they have sacrificed their health, their lives, and some have gone to extraordinary measures to protect their families as well. Many have worked way above their regular hours of work and have cancelled leave. Some have come out of retirement. So given this additional effort that was, invested by the healthcare profession in the pandemic, one can very easily justify why they are included in the rollout and in phase one. But then, of course, there will be questions around why traditional healers were included. Now, in South Africa, there are approximately 200,000 traditional healers. And almost 60% of the population tends to consult with the traditional healer before they present to the Western allopathic healthcare system. There is a Traditional Healthcare Practitioners Act in South Africa since 2007. And based on their patient-facing role, they were, according to the Department of Health, included in the phase one rollout. And so from a South African perspective, that is the one unique aspect relating to our allocation system. Of course, what remains to be seen is how many healthcare traditional practitioners would accept a vaccine and how the screening process would occur at that particular level. Now, other important concepts around vaccine allocation relate to vaccine acceptance. And we know that even amongst healthcare professionals, there are some people who would not accept vaccines. That number varies from country to country, with a vaccine acceptance sitting anything around 60% to 80% in different parts of the world. Now, for those who would accept a vaccine, one would have to look at distribution within phase one at various levels. And so categories of risk were established related to occupation. Obviously, those involved in aerosol generating procedures would be at highest risk, including laboratory staff dealing with specimens, screening, etc., to those in direct contact with COVID-19 patients, and then those in contact with suspected patients with COVID-19. And of course, the category 2 group would include those who have no contact with patients at all, but are nevertheless healthcare workers. And so in terms of sequencing the rollout, risk levels are extremely important in terms of occupation. Now, there are various approaches one could adopt to allocation of vaccines. And in an ideal setting, one would want to take both personal risk and occupational risk into account, using some form of algorithm or matrix. And if one has a digital platform, especially for healthcare personnel, then this would be easy to apply. I'll just quickly look at a possible example where we would take risk, age into account, comorbidities. And as you can see, as you have more and more comorbidities, you would score higher on this particular algorithm. We'd look at environmental exposure, ranging from administrative work to non-COVID work to COVID work, and then, of course, to ICU and high-level exposure, including, of course, emergency medical services. Now, what is contentious is the issue of whether one has had previous infection with COVID or not, or whether you have antibodies. And here, this varies from some arguing that irrespective of previous COVID infection, everyone should be immunized. And that would work if we had an adequate supply of vaccines. But where vaccine supply is limited, then we would look at duration. How long ago did somebody have a COVID infection? Of course, with those having a COVID infection 3 months or more before vaccination is possible, being prioritized for a vaccine. And of course, those who have never had a COVID infection being highly prioritized as well. Is there a high-risk family member at home when the healthcare worker returns home? And of course, important to factor in is whether a person will accept the vaccine or not. So based on this kind of matrix, one could divide people into high, medium, and low priority for the vaccine, with those at highest priority receiving the vaccines first. Now, provincial health departments have developed a screening tool that is much simpler than this, and that is being applied to screen access to the vaccines. So clearly, applying this kind of risk matrix across public and private healthcare sectors is important. Also looking at primary, secondary, and tertiary levels of care, it would generate appointments for vaccination with those scoring highest first. And this approach has the indirect benefit of staggering vaccination, because if one had an ICU setting and all the staff were vaccinated at the same time, those who developed side effects would be off work. And we would not want specific environments compromised due to people having to stay off work for periods of time. Of course, another possible approach is using an environmental risk approach. And here, specific environments would be targeted. In this case, for example, if one chose an ICU first, then all personnel in the ICU, including the radiographer who comes up to do the bedside unit X-rays, cleaning staff, etc. Likewise, high care units could be prioritized, as well as COVID-19 wards, and it would progress in this direction towards other environments within a hospital. The third approach could include categories of risk across the board. So here we'd look at patient-facing staff, non-patient-facing staff. And the electronic registration system that I'm sure you're familiar with uses this type of patient-facing approach. Of course, one could also look at categories of workers in terms of emergency ambulance staff being immunized first, followed by nurses or doctors and allied healthcare workers in that sort of direction or order, including progressively more and more categories of healthcare workers as we went along. So clearly there are different approaches, and we need to find an approach that is fair, equitable to all, and at the same time can be implemented fairly quickly. We've discussed the possibility of previous COVID infections, and of course, an important discussion in South Africa, because we have a dual health system, from an ethical perspective would relate to how do we share a limited supply of vaccines equitably between the private sector and the public sector. Now, there are various approaches here. We could consider, for example, the number of healthcare workers in the private sector versus the public sector. We could also consider the number of patients seen in the two different healthcare sectors. Now, here we know we have pre-COVID data that reflects that the public sector attends to almost 80% of the population, while the private sector sees only 20% of the population. So one could do an 80-20 split. One could do different other formulations around this, given the fact that during COVID, we know that the private sector was also overwhelmed with patients, and that all their wards were full, their ICUs were full. There are probably more ICU beds in the private sector in total. And so various other formulations are possible. As things stand in South Africa, the vaccines that we currently have are split so that a third goes to the private sector and 2/3 go to the public health sector. There is also the aspect of looking at primary healthcare versus hospital-based healthcare. And although the most infectious, sickest patients present to hospital are in COVID wards or in ICUs with high viral loads and exposing staff to high levels of risk, we also know that in the primary healthcare system that a large number of patients with mild and moderate disease are seen and treated by primary healthcare physicians, general practitioners, and family physicians, and that volumes of patients seen in the primary healthcare system are also significant. And so one needs to take all these factors into account to balance how one fairly distributes vaccines, between these two sectors. So if we think of a scoring system of screening, this would apply equally to the private sector and the public sector, and it would apply to general practitioners. So for example, with limited vaccine supplies, one would not allocate vaccines to all general practitioners in the first instance, but also screen amongst general practitioners in terms of risk, in terms of age, comorbidities, etc., to establish who would get access first. What we do know is that there was considerable disappointment when the AstraZeneca vaccine was not going to be rolled out any longer, and that within a short space of time, the J&J vaccine arrived and allayed anxieties to a certain extent. But we do need to take into account that this is an experimental vaccine. It has only been tested in trial settings. It does not have emergency use authorization, and it is not registered anywhere in the world. So unlike the AstraZeneca vaccine and some of the other vaccines that at least have emergency use authorization, the J&J vaccine does not have emergency use authorization, and we are working mostly on clinical trial data with respect to this particular vaccine. And so the rollout in South Africa is planned very much on around an implementation trial model where everyone enrolled in the trials will get the J&J vaccine. There will be no placebo arm, as usually occurs in a phase 3 trial. Of course, with any kind of rollout in this particular fashion, one needs to ensure a number of ethical principles are in place. So would there be equitable geographic distribution of trial sites around the country? And we know that as things stand, there are 2 trial sites in all the provinces, with 17 in total throughout the country. At the moment, mostly the tertiary public sector hospitals are being used. In terms of doses, we know that there would be initially about 300,000 doses available via this mechanism, with about 80,000 doses arriving every 2 weeks until we reach the 300,000 level. It is possible that there may be more doses that are more experimental vaccines that are distributed in this way. Of course, important to look at eligibility. Now, whenever we do a clinical trial, it is really important that one has very precise eligibility criteria. And so prioritization becomes important in this case because the implementation study is rolling out vaccines as in lieu of the AstraZeneca rollout. Another very important question is how voluntary would participation be? Now, usually when you take part in research, you are offered alternatives. So you don't have to take part in research. But this debate actually arose during the HIV era when antiretrovirals were available in South Africa only in the context of a clinical trial, giving people no choice. So because you had no other options, as we do now with respect to COVID vaccines, we are forced to take part in a clinical trial. We are forced to take part in research if we want to access the vaccine. There is no other vaccine available, and there are no alternatives. So this also raises questions around how voluntary participation in this type of implementation rollout would be. And certainly this would be a critique of the implementation study at this point in time when we have no alternative vaccines available. If we take part in these implementation studies, would we have access in the future when more efficacious vaccines become available? what level of community engagement has there been, and in terms of consent processes, how clearly have things been explained? Remember, when we speak about healthcare workers, we are not only talking about educated doctors and nurses and other members of the healthcare team. We are also talking about different levels of healthcare workers who may not have the same understanding of science. And so any consent information needs to be targeted to various levels of healthcare personnel in the system so that they can all understand their participation in this trial. And of course, in the event of vaccine-related injury, one would want to know what level of compensation there would be as part of the clinical trial. So clearly, it's been a rapid rollout, and as things progress, there are concerns being raised around equity, with lower risk healthcare workers in some institutions getting access to the trial before high risk healthcare personnel. And so questions are being raised around eligibility criteria. Are these being strictly enforced as they ought to be in a clinical trial and in any type of research in terms of the ICH GCP guidelines? Or is there just a haphazard distribution of vaccines? Is the electronic registration system working? Has it assessed in advance for risk and priority setting? And of course, these are some of the important ethical issues that need to be considered as this trial unfolds. So many of you are aware that ivermectin has also been rather controversial in the country, and clearly an important, whenever one takes part in a clinical trial, it's important to establish what other medications are being taken as as concomitant meds. And so would doctors who are taking ivermectin as prophylaxis be included in the J&J vaccine rollout? So that's another important consideration related to the current implementation studies. Now, many of you would have heard that the World Health Organization has deliberated on the situation in South Africa relating to the AstraZeneca vaccines, and the SAGE group of experts, of about 26 different experts from around the world, have recommended that the AstraZeneca vaccine rollout should continue in South Africa, assuming protection against severe disease, hospitalization, and death. We do know that a small study in South Africa with about 2,000 participants has shown that it does not protect against mild and moderate disease. But given that there is a probability that it would protect against severe disease, the WHO recommends rollout. And so that's an important discussion point around vaccine access and vaccine allocation in South Africa. Now, another very contentious ethical issue relates to mandatory vaccination for healthcare workers. And from an ethics perspective, we know that the principle of non-maleficence or first do no harm would require us to ensure that we as healthcare workers did not infect our patients or our colleagues by refusing a vaccination. There are various aspects of the law written into the Constitution, the National Health Act, the Occupational Health and Safety Act, and especially the Disaster Management Act, that requires us to consider carefully the legal stance around mandatory vaccination. We know that the Disaster Management Act COVID regulations has very specific statements regarding vaccination and treatment prevention as well. But in terms of intentional infection, so what happens if one declines a vaccine and then infects another person? And so here too, you can see that intentional exposure of another person to COVID-19 may result in prosecution for an offense, and that the Act differentiates between actual intention, eventual intention, and legally, one may not intend to kill another person, although you can foresee the possibility of that happening. And of course, somebody proceeds with a particular type of behavior in spite of foreseeing that their behavior may cause harm or death to another person. So that type of eventual intention is implied in Regulation 14.3. So that's an interesting consideration. Now, there are some religious concerns about vaccines, and we know that the British Islamic Medical Association has issued a position statement relating to the COVID-19 vaccine, AstraZeneca in particular, and they recommend the vaccine because it does not have any components that would not be acceptable to the Muslim community. Now, religious objections to vaccines are interesting. However, one would need legally to prove that one's religion specifically prohibits a vaccine of this nature in order to use a religious argument. Clearly, access to vaccines globally have been described by the Director General of the WHO as a catastrophic moral failure. So from an ethics perspective at a global level, we have many things to be concerned about. What is important with respect to COVID vaccines is that we need to ensure that everybody around the world has access to vaccines. And what we're aiming for is global recovery. So nobody is safe unless we are all safe. And access to vaccines at that level is an ethical imperative. So I'm going to thank you for your attention and invite questions that could be dealt with in the question and answer session later on. Thank you.